Well, thank you very much to the Anaphylaxis Campaign for inviting me to speak. So, obviously with food allergy, a lot of the emphasis is on children, rightly so. For the last 37 years, I've been seeing adults with food allergy, and I have to tell you, I'm seeing more and more and more and more of them. So I thought I'd just share with you some of the insights that I've had from that experience and the research that I've done. So I just wanted to start by talking about some real people who have real problems, and these are patients, all the patients that I've seen, and this is often the amount of information that I will get about what the problem is in the GP letter. So we have someone who has swelling, a rash, palpitations and collapse after eating fish, someone else who had quite a substantial reaction after eating king prawn curry, someone who had a nut allergy diagnosed in childhood, wanting an update, does he still have it? Someone who has a self-diagnosis of nut allergy, and that is something that I see an awful lot of. Again, someone who developed quite unpleasant hives and facial swelling after eating peanuts, and someone else who really feels strongly that wheat is causing rashes. So quite a mixed bag of people. So I just thought I'd start talking a little bit about how common adult food allergy is. And like pediatric food allergy, a great many more adults believe they have a food allergy than actually do. And this table just shows the list of prevalence data that's either been reported or actual or estimated rates from around the world, and you can see that generally the diagnosed rate is much smaller than the actual rate. People who have an adult food allergy tend to be more likely to be women. They tend to not have necessarily had a childhood allergy. Most of the people I see have never had a problem with allergy before. But they do often have other allergic conditions such as hay fever, asthma, and actually almost everyone that I asked, did you have eczema as a child, even if they don't have it now, they invariably have had eczema in childhood. Interestingly, this is a study which was looking at a group of adults, a very large group in thousands of adults over a period of years, and what they found was that there were all of these factors such as female sex, rhinitis, eczema, aeroallergen sensitization and asthma were all very good predictors of the likelihood of having a food allergy. What was actually not a good predictor, interestingly enough, was sensitization to food. In other words, having a positive IgE antibody test to food was not a good predictor that somebody would have a food allergy. And that's something that I will cover a little bit later on. Talking of foods, let's think about the kind of foods that adults might have a problem with. So we know that when there is a kind of natural tailing off of some food allergies, so milk and egg often a very early onset and then tend to be very rare in adults, although you do see it. Other foods such as peanuts and tree nuts start in childhood but continue to be a problem. And then you've got particularly crustacean allergy, fruit and vegetable allergy coming in adolescence and adulthood. This study, the one that I've just talked about from Patelis et al., which compared these two cohorts, found that fruit was the most commonly reported food, followed by nuts, vegetables, and seafood. Some of you with sharp eyes will see that chocolate crept in at number 5, and that is something that people do seem to feel that they have a problem with. Probably not a food allergy, probably more linked to the theobromines in the chocolate that can cause similar problems to caffeine sensitivity. This is a study from Texas, I believe, and here they again showed that shellfish, tree nuts, fish and soy were the most common foods. In the UK, there was an excellent study done in 1994, which again asked many thousands of people what foods they thought were causing a problem. And you will see, again, chocolate has suddenly crept in at number 1 here. I did a survey of 10,000 people a few years ago, and actually this is what I found people were reporting. I have to say I didn't actually ask them about chocolate. I didn't say, are you allergic to chocolate? I did ask about all the other foods, so that is slightly skewed. I don't know how many of them would have said yes, but what you can see here is that there has been quite a sea change in the types of foods being reported, with non-citrus fruits suddenly leaping up the charts, also nuts, fish and shellfish, and vegetables. So there have been quite a substantial change in the reported foods over the last few years. So sometimes the food trigger's obvious, and I always think, having worked in both paediatric and adult allergy, that, you know, paediatric allergy, have it easy. You know, that a child eats an egg and has a reaction, or they have some milk and they have a reaction. Of course, I know it's not true, but that's sometimes how it comes over. Is it's a little bit easier. Adults and, it has to be said, teenagers, adolescents, they don't just eat an egg or a fish. That would be very handy. No, they go out and they have pizza, and they have a smoothie, and they have something else and something else. And the problem with these foods is they're chock full of all sorts of different allergens, some of which you don't even know what they are. For example, Michelin's meals can contain all kinds of ingredients. Sometimes you don't really want to know where they came from. If they go foraging, as my son tells me, they've been foraging in Hyde Park. He's a chef. He's been foraging in Hyde Park. I said, oh, you know, okay. So sometimes it's very difficult to really know what's in the food that someone has had. Now, the most common plant food, the food allergy in adults is related to plant foods. And so if you look at all of the different fruits, vegetables and nuts, plant foods is by far the most common cause of symptoms. And the most common one is oral allergy syndrome, although I am on a campaign to call it pollen food syndrome, because I think it perfectly describes the problem. And it comes about because many adults who are sensitized to aeroallergens, in particular to pollens, will have antibodies against pollens that are wrongly recognizing the proteins in plant foods and reacting to them. So I usually say to patients, well, it's like you're eating pollen, and that's what your body thinks you're doing, and that's why you're having this reaction. Birch pollen is the main problem, and it's the particular main allergen in birch pollen, BETV1, that cross-reacts with so many of these plant food allergens, the PR10 allergens. BETV2 is a profilin, and I think you might have heard in the latex talk some mention of profilin. Profilins are ubiquitous. They're found in plant foods, they're found in animals, mold, slime, everything has a profilin in it. If you're profilin sensitized, you can have cross-reactions to huge arrays of foods, which is why sometimes people end up with hundreds of positive tests to plant foods that are completely erroneous, because it's the profilin cross-reaction that's occurring. Now, pollen food syndrome tends to cause immediate symptoms, usually with raw fruits or raw nuts, and occasionally with raw vegetables. So it doesn't happen when the food is cooked or when the food is digested. So it's always a very good question to ask about, can you eat apple pie? Because they always say, yes, that's the strange thing, you know. So that's always a good thing. And the other thing to know about it is that foods that have got a lot of protein in, so a lot of opportunity to interact with the pollen antibodies, can actually cause quite severe reactions in these people. And some people who get wheeze in the birch pollen season, and they may not have asthma, but they often can be wheezy in the birch pollen season, they can get wheezing when they have this reaction. So for some people, they can have a very severe episode of throat swelling and wheeze that, you know, is dangerous. And so this is a spectrum. Some people have such mild symptoms they don't even know that they've got them until I ask them about fruits, because they come to me about nuts and I say, what about raw apples? Oh yes, I have a funny feeling with that, but you know, so it's often there but unrecognised. These are the typical foods involved. The ones on the right are from a study I did a few years ago now, but very similar across Europe. They tend to be very characteristic because of the pollens and the proteins and the antigens involved. How common is it? Well, one of the reasons I sent a questionnaire out to 10,000 people was actually to find this out. And I can tell you that about 2% of the population have pollen food syndrome, but if you live in Scotland, it's very unusual. It's quite low level. In London, it's much higher, and having worked in London for the last 37 years, I can certainly say that I see a lot of people with this problem in the clinic. So what about other plant foods? Well, of course we see peanut and tree nut allergies, but in my experience, it's often as part of a pollen food syndrome rather than a standalone allergy, although I do see newly diagnosed Brazil nut allergy or a newly diagnosed cashew nut allergy in people who've never had that allergy before, and it's often very severe. Seeds, again, a big problem, coming up to be more and more of a problem as we have more and more seeds in our foods. I see people with severe reactions to sesame seeds, sunflower seeds, often have cross reactions to other seeds or nuts that contain similar allergens. The same goes for legumes, often a hidden allergen in foods. Lupin is one of the 14 foods that has to be listed on the packaging, but and that's because it can cause severe reactions in small amounts. It's not something that occurs in a lot of UK foods, but it does certainly occur and is important to think about. Fenugreek is a spice that's often used in curry powders. It is actually a legume, and I've certainly seen people who've had severe reactions to fenugreek. Buckwheat is another one that is on the rise, occurring in more things, perhaps because more and more people are not eating wheat, they're eating buckwheat instead, and so, of course, as day follows night, we start getting more and more people developing allergies to it. Lipid transfer proteins are pan-allergens, a bit like the ones that are involved in pollen food syndrome, only lipid transfer proteins don't get destroyed by heating or digestion or processing, and so they can cause much more severe reactions and anaphylaxis. Now, traditionally it was thought that they were mainly a problem in Mediterranean countries such as Italy and Spain and Greece, but actually we're seeing it quite often in our clinic in people who were born in the UK, who live in the UK, and we're in the middle of a study to really characterise the condition in the UK population at the moment. Of course, wheat and milk, being an adult clinic, I can't escape talking about wheat and milk in this lecture because a vast majority of the people who come through the clinic have often cut wheat out of their diet, and a number of them have often also cut milk out. So they're often considered by the patient to be an important allergen, but how important they are is probably certainly less important than is thought, although they are tremendously involved often in non-immune mediated conditions such as lactose intolerance and other irritable bowel and celiac disease. So, as I said, wheat is often reported as being a problem, but actually wheat allergy in adults is extremely rare. It is reported to be a trigger food, and as I said, there's a huge number of people in the population who choose to avoid wheat. 77.3% of Canadians choose to avoid wheat, which is a lot of people. So childhood onset wheat allergy undoubtedly exists, but it's normally over by teenage years. So the usual context for wheat allergy that I see in patients is it is part of a condition known as food-dependent exercise-induced anaphylaxis, and wheat is a very common trigger for that, and it's certainly something that I have seen in the clinic several times already this year. I do wonder whether, as exercise has become a massive part of people's lifestyle, whether we are seeing more of it now because of that reason. I'm not sure. I don't think anyone's really looked at that. So food-dependent exercise-induced anaphylaxis occurs only when people eat the food that they're sensitized to in close proximity to taking exercise. So it was reported a large number of years ago. It seems to be more common in women, probably because food allergy is more common in women. And there's a number of discussions about what could be causing it. Is it because the blood flows away from the gut during exercise? Is it because the exercise facilitates the uptake of these incompletely digested foods? So in other words, it gets rid of the food before it's really finished digesting it. Or is it the suppression of gastric acid that's causing this problem? I think the jury's still out on all this. Wheat is not the only cofactor. This paper showed that a number of cofactors were involved in causing reactions in people in the absence of exercise, such as aspirin, alcohol, and even food additives. So that's another sort of thing that makes it a little bit more complicated when it comes to diagnosis. So seafood allergy is the other big food allergy that we see, and it's a common allergy. 2.5% of adults reported that they had reactions to crustaceans in the survey that I did. So it's a common allergy, and Peter Burney's group have shown in the Europreval data that also there's a large number of people who have specific IgE antibodies to shellfish, especially to prawns. Prawns seem to be the one food that caused the most shellfish allergy in the studies that I've looked at. And often it's just prawns and it's not mollusks, and that may be because the kind of homology between the two species of shellfish is very low. In other words, there isn't much crossover between mollusk tropomyosin and shellfish tropomyosin. And when we talk about prawns, you know, what do you think of? Do you think about king prawns or North Atlantic prawns or tiger prawns or Madagascan prawns? What kind of prawns are you thinking of? Because there are a huge number of different prawns. And in fact, the prawns that we eat now are very different to the ones that we were eating before, because the prawns we used to eat were crangan, which were caught. But more recently, the farming methods were developing farming to the tiger prawn, but actually that's been largely overtaken now by this Penaeus phenami, which is the white leg shrimp or prawn, and it's the king prawn. And of course, there's a massive amount of king prawns now available. So you can see on the plate on the bottom that, you know, you start with a little shrimp at the top and you end up with the Madagascan prawn at the bottom. And they are all a little bit different, so not all one size fits all. So tropomyosin is the main allergen in prawns, and it's the pan-allergen, so it's in lots of different species of prawns, as well as the kind of standard prawns. And also there are other allergens. We don't really know a lot about them. We don't know how relevant they are in prawn allergy, but it's an important thing that we need to find out. This table just shows you what we know about tropomyosin and all the different species that it's been sequenced in. But you can see that there are these other prawns, and so therefore there is a potential for there to be cross-reactivity between some of these other proteins, which may be important in diagnosis. What about foods that are not involved in IgE-mediated allergy? So wheat, rye and barley is commonly manifests as a problem with celiac disease. Most of the people I see have had a celiac screen which has been negative. So I think you know, it's a very common thought that they have celiac disease, but often they don't. Milk and milk products, well, again, lactose intolerance, it does occur, and of course it occurs at different rates in different populations. but certainly can be something masquerading as an allergy, although the symptoms are very different. And then you have the fermentable carbohydrates, or the FODMAP foods, a diet that's very commonly used in irritable bowel syndrome with great success. And I have to say, it's a diet that I do often also use in the food allergy clinic in people who do not have a food allergy or food intolerance to other things. So other substances, well, additives are often thought to be a problem. People still think additives are a problem, and they sometimes are. Sulfites can cause problems, particularly in patients who have asthma. They're probably the main additive that I would see as being an issue. And then you have the naturally occurring food chemicals, and I seem to be seeing more of this sensitivity to the naturally occurring histamine and other biogenic amines in foods, which can cause these kind of food allergic type symptoms, mimicking them, and it can be very severe. And the most severe expression of this is something called scombroid poisoning, which frequently occurs after people have eaten mackerel or tuna, and these are fish that have very high levels of histidine, which then is degraded to histamine after the fish has died. So if you have old fish, watch out. So how do we diagnose food allergy? Well, in adults, it's just the same as children. The history is really going to give you all of the really important clues. And of course, there's a whole range of things you need to ask about, as well as the reaction and the foods that were involved. You need to know what they are eating normally, what symptoms they have, what other medical history. Because unlike children, adults are often taking regular medications that could actually be causing their symptoms. So it's important to rule that out. It's important to rule out latex allergy, and it's important to take note of any cofactors that might be important in this case, bearing in mind that I often see what I would call now young people who are often out drinking and dancing at the same time, and possibly taking some other recreational substances as well. So I have to tell you that cannabis does have a lipid transfer protein in it. In order to help out with this very important problem, a group of us got together and produced some guidelines for taking an allergy-focused history, what kind of questions to ask, and then how to interpret the answers. And that is freely available if anyone's interested. It's freely available to download from PubMed. There are very good tests which have good negative predictive values, the skin prick tests and specific IgE tests, and the negative test should be interpreted with caution if the history is very good. So the problem with these tests is they do have a very poor predictive value. There's often not very good agreement between skin prick tests and specific IgE blood tests. There are no good predictive values for adults, and people who have lots and lots of high total IgE will often have lots of small positive tests which may not be relevant. And of course, if they're sensitized to tree and grass pollen and house dust mite, they may have positive tests to hazelnuts and peanuts and shrimps because of the cross reactions between those foods. So here are two arms, and one of them has food allergy and one of them doesn't, but you can see that they both have positive tests to peaches and hazelnut and almonds. So it's important not to take the tests at face value. The history and the tests together are ideal, and that will often make a diagnosis. And in fact, there's been a couple of papers published suggesting that the history and the test is all that you need for some conditions such as oral allergy syndrome or pollen food syndrome. So which tests are most useful? Well, in my experience, and this is my experience and everyone's different, skin prick tests of pollens to seafoods and prick-to-prick tests of fresh foods are the most useful. So the lady at the top had completely negative blood tests for everything that we tested for. She was actually sensitized to a weed called mugwort, and she was having cross reactions to melon and fenugreek. as well as several other plant foods. And it was only by skin prick testing her with the fresh foods that we got to the answer. The lady at the bottom had completely negative tests to prawns, but you can see, I hope, that the king prawn is something you wouldn't want her to eat, really, given the large wheel on the skin prick test. Specific IgE tests are useful to confirm sometimes skin prick test results, particularly useful for seafood or to check whether milk and egg allergies resolved. And then, of course, we have component resolved diagnosis, which is where you have individual allergens, which are either on their own or in a microarray, such as you've heard already, the ISAC microarray. So this is molecular allergy testing. You're testing an individual allergen. And, you know, there's been a lot of studies looking at component resolved diagnosis. A lot of it's been done in children rather than adults. But it's been suggested that if the tests are inconclusive, then components may be useful. And these are just some of the ones that might use. The ones in bold, so ARA-H2 is a very good predictor for peanut. GlyM4 is a very good predictor for pollen food syndrome for soy. CORE14 is a very good predictor for hazelnut allergy, whereas CORE1 is a good predictor for pollen food syndrome, as is ARA-H8. So there are some around and they are useful. But I think sometimes we do them because it's interesting for us, but it's not going to make any difference to the patient. So I think it is an important point to remember. And of course, they're very expensive, as the immunology guy who looks after our labs keeps telling me. So peanuts, I've just said ARA-H2 is useful. ARA-H8 is the major birch pollen cross-reacting allergen, whereas these are other ones. And the bottom one, wheat, omega-5 gliadin, has been around for a long time, and that is very useful in the diagnosis of wheat-dependent exercise-induced anaphylaxis. So, of course, there are other tests. I'm sure you will know about these. These are for non-IgE-mediated or non-immune-mediated problems. But, of course, there are a lot of tests, as you know, we do not recommend and are not recommended either by the American Academy of Allergy or by the European Academy of Allergy, especially IgG and IgG4 testing. Of course, there's exclusion diets. Andy, could you just tell me how much time I've got left? Sorry. Okay, great. Exclusion diets where you're avoiding the food for 2 to 4 weeks or for up to 6 weeks if it's not an IgE-mediated problem. There's oral food challenge, which we undertake. I do not as many as probably you would do in children, but certainly not as many as they did in the LEAP study. But, you know, we do them quite often to check for resolution of a childhood allergy or to check if someone's had negative tests, do they really still have a problem with the food. I'm just going to zip through some of these because I just thought you might be interested. Over the last 5 years, we've done 123 different foods that we've challenged, including jelly babies, edible glitter, and various other interesting things, so quite a lot. The important thing is to say that a majority of the challenges were negative, but there was quite a number of those that had positive tests. So, you know, I think where there is doubt or discrepancy between the history, the tests, a challenge is always a good and important thing to do. And then the positive challenge, 14% of them, most of them were to tree nuts, some of them to seafood, and some to fruits and peanuts. And again, 37 of these had negative skin prick tests and specific IgE tests. So half of the people with the positive challenge had negative tests. So again, it's this thing about the face value of the tests. So let's come back finally to our patients that we saw at the beginning of this talk, and was it food allergy? So this was a lady who had reactions to mackerel and tuna. She'd eaten cod since then and she was fine. Her tests were all negative on skin prick test and blood test to seafood, especially to fish. And so we deduced who probably had scombroid poisoning, and mackerel is one of it's the highest amount of histamine of any fish. This guy had a king prawn curry meal, which he had quite a substantial reaction to it. Actually, then he said, but I ate a prawn sandwich and I was fine. So my usual response to that will be, bring me in some prawns and we'll do a skin prick test with them, which is what he did. What we did first was we did some skin prick tests to the shrimp, which was negative. We did blood tests, which were really not, they were borderline to shrimp and lobster, but very strongly positive to crab. But with the prick test to the king prawn, that was 9 millimeters, but actually the Atlantic prawn was completely negative, and the tiger prawn was only 3 millimeters. And we challenged him 2 weeks ago to tiger prawns and Atlantic prawns, and he could tolerate them both. So he's a happy man because he loves prawns. I just don't have prawns when you go out, because you can guarantee that the waiter may not know the difference between a king prawn and a tiger prawn. So nut allergy in childhood, pistachio cookie had caused oral and orbital swelling. Actually, he seems to be someone who has pollen food syndrome, because his core A1 is positive, but all his other hazelnut allergens are negative. But I'm not quite convinced about the pistachio nut cookie, because pistachio nut's not normally part of oral allergy syndrome. So I think we need to do some more work with him. This was a lady who self-diagnosed nut allergy because she'd had lots of reactions to nuts. She'd eaten a salad, she thought it was a nut oil, but the salad had raw mange 2 in it. And actually, she was someone who had completely bang to right pollen food syndrome. All her tests to nuts were negative, except for core A1 and ARA-H8, which cross-react to birch pollen. But her soy Glyam-4, which is the other soy cross-reacting birch pollen allergen, was also very high. So I said I thought it was the mange 2 that had caused the problem because it was raw, but it was a severe reaction. This lady had hives and facial swelling to peanuts, but then she'd also had them to macaroons, Marmite, pot noodle and raisin. Now, if anyone can tell me whether those have anything in common, I'd be interested to know, but my feeling was they didn't, and that this wasn't a food allergy at all. And in fact, we did give her, all her tests were negative, and we did challenge her to peanuts just before she went on holiday, and she was fine, so she was very happy. And finally, this girl had cut wheat out. She was sure it was causing a rash. Actually, it wasn't just a rash. She was getting giant hives. She was feeling faint 45 minutes after eating foods that contained wheat. So she'd had a pizza on a night out. Walking home, she'd reacted to pasta, flatbreads, and a sandwich. But all the reactions, when I went through it with a fine tooth comb, were linked to alcohol or exercise. So we did test her for wheat, and she had a strongly positive omega-5 gliadin, which is a very good indicator that this is wheat-dependent exercise-induced anaphylaxis. And in fact, I advised her to cut wheat out entirely because she was at a high risk. So in summary, adults have a constellation of symptoms and foods. They often don't have a history of reactions to foods previously. We're usually looking at seafood or nuts or fruits. They often have hay fever or asthma or eczema or all three. The history is vital, as it is with all food allergy diagnosis, but it's essential in adults to test for aeroallergens, and not just to test for foods in isolation to avoid false positive tests. Remember, there are minor food allergens which are becoming more important. I see a lot of people, probably about 2 or 3 a week, who have idiopathic urticaria angioedema, which is not food related but always linked to food. And exclusion diets, when they're properly conceived and nutritionally balanced, can often offer symptom relief, especially in people who don't have an IgE-mediated food allergy. It gives them some autonomy and control back over their lives. So, thank you very much.
Great, thanks very much, Isabel. Great talk. Any questions? So, patients who have pollen food syndrome often love to eat fruit.
Yes.
And they hate the fact they can't eat it. And if they have mild reactions, some of them just eat apples anyway.
Yes, I know.
And some take antihistamines, as you know. So I'm sure I'd seen some data somewhere, maybe from Claire Mills, showing that even if you disrupt it, if you put the fruit in a food mixer and whiz it up, it disrupts the protein sufficiently so that in vitro IgE won't bind to it. Or other patients I've spoken to said if I just put it in the microwave for 10 seconds, that can help as well.
The
So
have
you got any tips for people?
Okay, microwave is good. I've never tried it, so maybe I'll go home and microwave an apple now. Often what I tell them is to try other varieties, because we know that different apples have different levels of ability to affect different people. So usually with pollen food syndrome, it's the green apples, Golden Delicious, Granny Smith. So I often say try Pink Lady, that might work. Sometimes with LTP allergy, it's the other way around. Certainly, stored apples may have more allergens than fresh apples. Right. It depends which allergy you're talking about. But the variety is important, and I think what Tanya was saying is really important. They think, oh, I can't eat anything because I can't have apples and pears and peaches. Well, actually, there's a whole range of fruit they can have that they don't normally eat it, so they just think, I can't eat anything. So it is about giving them a kind of, you can have all of these, and there are some fruits, of course, that are less likely to cause a problem in certain types of pollen food syndrome. It depends which allergens they're sensitized to. So it's important to know that yourself so that you can give that information to them. But yes, patients tell me microwaving works, but I've never tried. Okay,
I expect you have to prick it first because I'm worried it might explode.
Well, you could have an exploding apple, that might be quite fun.
Any questions? So it's what you showed, the data you showed about the prawn is really important because it'd be so easy to get that wrong and just assume a negative prick test to the little prawn was enough to rule it out, whereas in fact they may be allergic to the king prawns. Do you find it makes a difference if the prawn is cooked, or does it have to be raw?
No, we only have a prick test with cooked prawns, and actually there's some studies showing that there is no difference between them, and that's because the shellfish allergens, unlike fruit allergens, are very robust, and they can even remain in the cooking oil after the food has been cooked, which often causes, for people with prawn allergy, they can often have minor reactions in a restaurant, even if they're not having prawns, especially if it's a Thai restaurant, because they don't always wash the pans after they've stir-fried in the wok, and so there might be allergens still in the oil when your stuff goes in. So I always say to people to be very careful when they're eating, especially Thai, Vietnamese, or even sometimes Chinese. Yeah.
Okay, good advice. Yes.
As a freelance dietitian, and I know others in that field experience the same, we're quite often getting people calling us out of the blue saying they've got multiple allergies, they think it might be this or that. And we're aware that some of the sort of testing that can be done, online, like hair analysis and things like this, aren't reliable. What practically could we suggest to them in terms of getting some proper testing underway?
I always say, go to your GP, because whatever they've got that there's a symptom, it could be a very serious condition that's nothing to do with allergy at all. So I think it's really important that you encourage them. There is no testing that they can get without going to their GP that is going to reliably tell them that they've got a food allergy or they haven't got a food allergy. So it's really important that they go through that route. So I see private patients very occasionally, but I always insist absolutely that they have gone through their GP or an allergy consultant or somebody else, so that they can validate some of these other, just to make sure there isn't something else going on that's being masked, especially in older adults. I think it's really important because there could be a whole host of other reasons, so they need to do that so that then the GP can make sure they get to the right person. There is nothing, I mean, you know, sometimes people will say, well, I cut out wheat and I felt better, or I thought it was milk and I cut that out. But at the end of the day, they're still not going to get a proper diagnosis unless they go through the GP. And we must encourage that, because the GPs must be encouraged. There's new, nice guidelines for quality standards coming out. They're only sadly applicable to children at the moment, because there's no nice guideline for adult allergy, food allergy. But it's really important, because the GPs will now have those, the kind of push to make a proper diagnosis. And I think that's why it's really important that we encourage that more than anything else.
Could I ask two questions?
Of course.
First one, I have never seen a case of lupin sensitivity. Does this mean I've missed it, or is it something fairly recent? Because it's one of the 14
It's
foods
one of,
which
yes,
have
it's
to
one
be,
of the 14.
you have to say whether it's there. So how common do you see it?
I've probably seen about 3 in 37 years, but only really those have all been in the last 5 years. So I think it's something that we don't come across a lot. So it's often, it used to be in gluten-free foods quite often. It's not something you will often see, but it's something, if someone's had a very severe reaction. I had one lady who had anaphylaxis twice, 2 years apart, both times eating at a function where the food had been brought in from abroad, because it's commonly used in place of soy in places like Italy and sometimes in France and other places in Europe. So we tested her for lupin, and it was, you know, a really high total IgE. Then she found out that we were thinking, how could she have become sensitized to lupin? She'd been using a face powder for 9 years that contained lupin. And that goes back to what someone I was talking about this morning, Hazel, I think it was, about all of these things have got stuff in them, and we don't know what it is, and is it going to cause a problem further down the line? So I don't think you've missed them. I'm sure you wouldn't have missed anything, but it isn't as common as other allergens.
My second question concerns silver birch sensitivity and oral allergy syndrome that goes with it.
Yes.
In the first place, the amount of silver birch that is in the air over the last 2 decades has increased.
Yes.
And this is because Green Party, I think, have insisted that silver birch trees should be put near schools and they shouldn't look at non-tree areas. Do you ever give advice? Because you can get rid of this problem completely by telling the people who put in silver birch trees that they should put in female trees only, and therefore there's no silver birch pollen. That was one thing. But the other question about silver birch sensitivity, do you see anaphylaxis? Because this is anaphylaxis, we're talking about it. I mean, oral allergy syndrome with silver birch sensitivity is fairly common, but how often does anaphylaxis occur with it?
Well, I don't think true anaphylaxis can occur because of the nature of the way it works, but I have seen people who've had very pronounced oral tongue swelling, very pronounced throat swelling, so pronounced that they can't swallow. And these, sometimes people with birch pollen allergy, as you know, they get very wheezy in the tree pollen season. And what will happen is they will have this massive reaction. They can't swallow, and they're wheezy because it's like they're having a birch pollen reaction. So there is certainly people who, if they have asthma and they are having these severe reactions, then we would often, we have actually, not me because I'm not a doctor, but we have prescribed adrenaline in some cases for this condition because because it can be very severe. And I think when you're having soy milk is one of the worst because it's like a whole load of allergens in a nice emulsion that's coating the throat, and there's lots of protein in it, and I think that's why it causes such severe reactions. So for some people who've had very severe reactions to tree nuts and soy, who have asthma, who have wheeze and severe swelling, we would advise them to carry adrenaline.
Okay, I think we've used up enough of your time, Isabel. Thank you very much, Ken. Well done.